Welcome to this talk on paracetamol and its use in the management of joint pain and osteoarthritis. Paracetamol, of course, may also be known as Panadol and acetaminophen. I am Dr. Martin Johnson. I am a GP with a long-standing interest in chronic pain. I am Vice President of the British Pain Society. I'm also the lead for the Royal College of General Practitioners in the UK for chronic pain. On screen is my disclosure for your information. What I would like to do now is set the scene for you, go through some basic details about chronic pain, paracetamol, and also some of the other drugs that are used to treat chronic pain. Here is a very famous picture from the Wellcome Library. Pain may be the oldest symptom. It is one that we all, unfortunately, will experience in our lives. This picture was painted in 1799 as a graphic presentation of the devil digging his fangs into a very inflamed foot and snorting fire. Many people will present to you with chronic pain or acute pain. Some causes will be obvious, but some are not. This is supposedly one of the oldest nationally advertised remedies specifically for pain. It was published around 1845 and was given the title of painkiller and was distributed by the Christian missionaries around the world. Its ingredients, mainly opiates and ethyl alcohol, were entirely natural. Pain often is very emotional and creates a lot of headlines across the globe. Here is one from Scotland where they were having to ship patients to England to manage part of their chronic pain, which was causing a lot of anxiety in Scotland. Pain is such a huge problem across the globe. It is all around us in various forms and many different types. The only way for us to manage this is for us all to take responsibility. I would now like to demonstrate to you the differences between acute and chronic pain. Acute pain is what we fear the most, and here it is graphically shown by three major sporting injuries. Acute pain starts with an insult, which may be an injury. It might be a burn. It might be an infection such as shingles. But over a period of time, it causes changes in the nervous system, which then causes chronic pain. This adaptation can take place over, as it says here, between 3 to 6 months, but for sometimes it can be a lot shorter than that. So often we define pain as any pain that persists beyond the point of normal healing. It is important to realise that the presence of chronic pain has an impact on all areas of functioning of the human body, including emotional, social, and physical. It also causes problems for those around us, our colleagues, and our family. With the persistence of pain, the extent and depth of these consequences we know now expands and also evolves, so the pain gets more severe and the effect on us as a human being becomes more severe. There are many significant surveys that show that pain has a dramatic socioeconomic burden affecting people of all ages and walks of life. And it's been shown that patients with painful conditions consume almost double the healthcare resources of the general population. Here is a classic osteoarthritis knee. Osteoarthritis, or OA, is the most common form of arthritis and it generally occurs in people older than 45 years of age. However, I have personally seen it in people in their mid-20s. Risk factors for developing osteoarthritis include genetic risk, the female sex, previous trauma, advancing age, and of course the obesity issue, which is affecting many parts of the globe. The osteoarthritis changes seen are clearly shown in the diagram, with osteoarthritis being defined as characteristic structural alterations in the joint. Joint pain, of course, is a symptom of many different types of musculoskeletal problems, including osteoarthritis. The main symptoms of osteoarthritis are joint pain and, of course, stiffness. The stiffness tends to be more severe first thing in the morning. Over time, the joint becomes misshapen or often larger due to changes in the synovium. So now I'd like to give an introduction into paracetamol. Paracetamol first came onto the market as a children's elixir in the US in 1855, and then tablets were introduced into the United Kingdom in 1856. Paracetamol works both as a painkiller and also reduces fever, but it is not known to have anti-inflammatory action. The exact mode of action of Panadol or paracetamol is not well defined, but it is thought to involve inhibition of prostaglandin synthesis, primarily within the brain. Plus, it is now generally accepted that paracetamol inhibits the cyclooxygenase or COX enzymes, which produce prostaglandins throughout the body. Now I'd like to give you an overview of anti-inflammatories or NSAIDs. There are a variety of anti-inflammatories or NSAIDs used in mild to moderate pain. For example, aspirin, ibuprofen, naproxen, and diclofenac. NSAIDs inhibit the production of prostaglandins, but unlike paracetamol, this occurs throughout the body, not just in the brain. They act by blocking the COX-1 and the COX-2 enzymes that are responsible for producing prostaglandins throughout the body. As a result, NSAIDs can effectively relieve the pain associated with tissue damage and inflammation. The anti-inflammatory effects of NSAIDs are dose dependent, with higher doses required to produce significant anti-inflammatory action. However, the inhibition of prostaglandins that are not involved in pain and inflammation, including those that protect the lining of the stomach, lead to some of the well-known adverse events associated with anti-inflammatories. For example, the development of stomach ulcers and increased bleeding. Pain management guidelines differ in their recommendations with regard to NSAID use. In patients with OA, topical NSAIDs and paracetamol are recommended as first-line treatment for mild to moderate pain in addition to core therapies. Oral NSAIDs or opioids should be considered in addition to core therapies when pain relief is no longer effective. Now I'd like to present some of the basic data on epidemiology of both chronic pain and also osteoarthritis. As you can see from this map of the world, there is an extreme difference between different parts of the world. This is due to many factors, such as methods of collection, differences in population, cultural beliefs, and many other different factors. Look at the difference in North America, with Canada showing a prevalence of 19% and the USA 43%. And then turning to Asia Pacifica, we get huge differences. Cambodia 61%, Malaysia 7%, and Myanmar at 5.9%. Now I'd like to turn to one of the reasons that we are seeing a dramatic increase in chronic pain across the globe. Over the last century, we are seeing the population aging, with elderly people now comprising the fastest growing segment of the world's population. Thus, with the prevalence of chronic pain increasing with age, we have an increase of joint pain and also neuralgias. This recent study, which was published in Pain, the International Journal for Acute and Chronic Pain, showed how common pain is, with the commonest pain being in the lower back at 30% and 24% having pain in the knee. This landmark study from the UK, which was published in 2010, proved that the old saying, "nobody dies from chronic pain," was incorrect. Indeed, there's a correlation between persistent pain and also a risk from mortality, especially from cardiovascular factors. I had the privilege of presenting this paper at the Prime Minister's office in the UK, which then changed some of the policies which the government was imposing with regard to the management of chronic pain. In 2008, the 150th Chief Medical Officer's report highlighted the issues with chronic pain, and helped us start the journey to develop a pain strategy for the UK, with a report stating that 25% of pain sufferers lose their jobs. 16% of sufferers feel that their chronic pain is so bad that sometimes they want to die. You can also see from the screen that there is a vast number of people that have had treatment for osteoarthritis, with increasing numbers, as we've discussed before, due to the elderly population. It is estimated that by 2035 that there will be 8.3 million people diagnosed with osteoarthritis in the UK. That's osteoarthritis of the knee. At present, there are 8 million presently diagnosed with all forms of osteoarthritis. This extremely important large meta-analysis was published in the BMJ Online in 2016. It estimated that around half of the UK population had some degree of chronic pain. The previous study, which has always been quoted, which was from the European Journal in 2006, had only estimated a quarter of this figure of 28 million. You can see from these figures that both osteoarthritis and pain put a great burden on both the community and hospital healthcare resources. But remember, many people simply do not present to any healthcare professionals, believing that nothing can be done, and osteoarthritis is simply part of a normal aging process. Unfortunately, when those similar patients present to their healthcare professional, this is unfortunately then reinforced. The Global Pain Index, GPI 2017, is an in-depth study commissioned by GSK Consumer Healthcare to look into the attitudes towards physical pain and the impact that physical pain has on lives around the world. Here we are specifically looking at the burden of OA and joint pain, which is extracted from the GPI. As you can see, the 2017 survey covered 6 continents, 32 countries, with 19,000 people being interviewed across the world. It also includes just over 2,000 individuals with osteoarthritis and 8,500 with joint pain. And as you can see, they are fairly equally distributed in both sexes for both osteoarthritis and also joint pain. As we can see, the prevalence of osteoarthritis and joint pain increases as age progresses. In terms of osteoarthritis, the first signs of development are in the mid-20s, similar to joint pain. However, there's a larger number of people in their 20s suffering from joint pain from other causes, for example, soft tissue injuries to the knee. It steadily progresses throughout the 30s, 40s and 50s. By the time we reach the 50s, then osteoarthritis increases beyond the point of joint pain. Now we will look at some data extracted from the GPI. This is for joint pain. As you can see, 55% of people felt emotional due to their pain, feeling worried about their pain. And also 70% of people say it affected their ability to get a good night's sleep. Hence why it is so important to take a good history around sleep. Overall, 77% of people with joint pain sufferers stated that their quality of life had decreased due to the chronic pain. Here we now see the data for osteoarthritis, where there is a slight increase over joint pain in terms of the number of people that said that the quality of their life has decreased due to the chronic pain. Picking out a couple of bullet points for osteoarthritis, as you can see, 40% of people have avoided sexual relations due to the persistence of their joint pain. Again, we've got 73% saying that pain had affected their sleep pattern. Now I'd like to turn to the all-important pain treatment. This talk is not meant to be an all-encompassing how to manage chronic pain talk. However, over the years, I have managed to distill certain extremely important points which I believe are essential for any patient undergoing pain treatment. Firstly, at the very start of their journey, accurate pain assessment underpins all aspects of pain management. If we don't get an accurate assessment, then the journey will go off in the wrong direction, and thus they will be referred to the wrong person, they can take the wrong treatment, lots of other reasons. You should not become distracted with a biological diagnosis, which is what we're all trained in so much, because that will be at the detriment of the psychosocial aspects of the case. Though, of course, serious pathology has to be ruled out first. Always believe the patient and their family. Assess pain severity, physical function, and psychological state. And as you've seen from the previous slides, sleep is very, very important to assess. Use collaborative priority and goal setting techniques. Management also requires a patient-centered, multifactorial, comprehensive care plan. Address biopsychosocial factors and associated features such as depression, fatigue, and sleep, because they will often be present in many of these patients. I would now like to introduce you to a very simple way to assess pain, better known as the 4Ds. In this triangle, you can see 4Ds, or maybe 3Ds and a P. Firstly, we need to assess their disability, which is the social aspects of their pain and how much it actually affects them in terms of their movements, etc. Importantly, we need to know the distress that the patient is under in terms of both their sleep and also their emotional state. The pain itself is important to assess and quantify. Pain also may be known as dolorosa, hence the third D. Dolorosa means suffering. And importantly, the D in the middle are for drugs. What drugs have the patients taken before? What side effects have they got? And also how effective have previous drugs been? In the previous slide, I introduced it as a fairly simple method, but we can also make pain assessment more complex, as demonstrated by this diagram. Pain is central to any part of assessment, but like the layers of an onion, we need to peel them the various layers back to actually see what is going on beneath it. The attitudes and beliefs of the patient towards their chronic pain is so important to address. Many have very strange attitudes towards their pain. We've talked about the psychological distress. Also, many patients with chronic pain develop illness behavior. For example, they may go to bed and not get out, they may refuse to walk, and many other factors as well. And also there's the social impact that chronic pain has on both the patient and also their family and also their work colleagues. Fundamentally, it is very important to believe the patient, even if their history does sound rather strange. And thus the statement, pain is whatever the experiencing person says it is, existing wherever he or she says it does. One of the few things that physicians often remember from medical school about pain treatment is the WHO guidelines to pain. In 1986, the World Health Organization, or WHO, established the first recommendations to trigger the treatment of cancer pain. These recommendations were based on the WHO analgesic ladder, a stepwise approach to the use of various analgesics, as we can see demonstrated here. At step 1, we have the simplest stage for use of OTC analgesics such as paracetamol, anti-inflammatory and aspirins. Mild to moderate pain introduces codeine, possibly with other OTC analgesics, and sometimes an adjuvant therapy. Step 3 is the strongest step, where you get morphine, oxycodone and other adjuvants added. What we have to remember that the WHO ladder was designed for cancer pain. Last year, in 2016, there was a leader in the BMJ saying WHO analgesic ladder, a good concept gone astray. What they point out that treating chronic pain patients in the same way as cancer pain patients, especially titrating opioids to their pain, exposes patients to risk of harm. Plus, it also sets unrealistic and damaging expectations for patients. Here, I would like to introduce you to one of the most important concepts, in my opinion, in terms of the management of chronic pain. This comes from the Pain Toolkit and is the pain cycle, which was published by Pete Moore. I keep this on my desk in a laminated form and use it to demonstrate this pain cycle to any patients that have a difficulty coping with chronic pain. Here we see persistent pain starting. That leads to the patient becoming inactive or sometimes overactive. We get drug side effects developing. Due to those drug side effects and also the chronic pain, fatigue starts, the patient becomes weaker, they gain weight, they then start to develop stress, anxiety and tension, and then other emotional difficulties start, like sleep, anger, fear and frustration. And then that leads to time off work and also family and money worries. Therefore, to address chronic pain, we need to intervene at several different stages around this pain cycle. As healthcare professionals, we often think that we are supporting our patients very well. But consider this. Patients with long-term health conditions, including those with chronic pain, usually only receive an average of 3 hours of professional care per year. For the other 8,757 hours, patients thus need to become active self-managers and look after themselves. We can see that the self-management of pain is a vital part of the treatment of this condition. For many, an important component of this self-management is the use of over-the-counter or OTC medications. In most countries, there are 3 main classes of painkillers available over the counter. Firstly, paracetamol. Secondly, the anti-inflammatory OTC drugs such as aspirin, ibuprofen and naproxen. And in some countries, we also find codeine and dihydrocodeine available, usually in combination with other drugs such as paracetamol. So, what are we using over-the-counter analgesics for? This UK consumer survey shows that we're using it for headache, muscular aches and pains, back and joint pain, and also arthritis and rheumatism. OTC medications have greatly facilitated consumers' ability to self-treat their pain, arguably reducing some demand on the healthcare systems, with up to 70% of the population in Western countries using OTC medications regularly. This extremely large survey from Australia looked at the percentage of patients with labelled contraindications, warnings and precautions to OTC medications. It was found that paracetamol was suitable for use in at least 98% of adults, which was significantly more than the approximately 80% for ibuprofen and aspirin. This study shows the efficacy of paracetamol in the elderly. A double-blind study was conducted with 3 different arms, firstly of paracetamol at 4,000 milligrams per day, ibuprofen at its lower dose of 1,200 milligrams per day, and also the higher strength ibuprofen at 2,400 milligrams a day. And it showed that paracetamol was effective as prescription strength ibuprofen in reducing pain. There are several treatment goals for osteoarthritis, such as reducing healthcare costs, reducing joint pain and stiffness, maintaining and improving joint mobility, reducing physical disability and handicap, improving health-related quality of life, limiting the progression of joint damage, importantly, educating the patients about the nature of their disorder and also its management, and also, and finally, minimizing side effects. Good pain management, as we can see, is central to all of this. So what goal do we actually set patients in terms of their reduction of pain intensity? You would think 100%, but of course it depends on what baseline has been set to start with. And in many patients with chronic pain, because they've got a chronic disease causing that chronic pain, 100% reduction is often impossible. And so the international guidelines state that the evidence is growing that chronic pain patients should regard pain intensity reduction of 50 to 70% as a clinical success. And ideally, we should aim to get pain reduced to no worse than mild. There are common features to several of the major international guidelines, such as the EULAR guidelines from Europe, the NICE guidelines from the UK, and also the American guidelines. And on this slide, you can see demonstrated what are the 3 key points. Firstly, there are 3 core interventions at the heart of all guidance: education, exercises, and weight management. Treatment of a person with osteoarthritis should be individualized, take into account risk factors, comorbidities, localization of the osteoarthritis, the level of pain, and the wishes and expectations of the patients. The second point is that topical NSAIDs should be considered ahead of oral NSAIDs and also COX-2 inhibitors or opioids. Topical treatments have clinical efficacy and are safe in the management of both hand and knee osteoarthritis. Also, topical treatments are used in self-management, which helps change health behaviour to a positive nature. The third point is that all oral anti-inflammatories have similar analgesic effects, but vary in their potential gastrointestinal, liver and cardiorenal toxicity. Therefore, when choosing the agent and also their dose, patient risk factors such as age should be taken into account. At this stage, also opioid therapy may also be considered if appropriate, though of course you must consider the risks. Summarising the NICE and EULAR guidance, we get the following advice regarding the pharmaceutical treatment of osteoarthritis, giving an individualised approach to pain management. Firstly, paracetamol should be considered the oral analgesic of first choice, and if it successfully reduces the pain, it is the preferred long-term analgesic. Secondly, we should consider topical applications of NSAIDs or capsaicin. The third option, if paracetamol and topical applications of NSAIDs are not working, is to use non-selective NSAIDs combined with effective gastroprotective agents or possibly selective COX-2 inhibitors. These drugs should be used in patients that have been unresponsive to paracetamol or patients that have an increased risk of gastrointestinal issues. A fourth option may be opioid analgesics with or without paracetamol. And finally, the other drugs such as chondroitin, etc., which may modify joint structure. No drug class is without some risks. And next, I'd like to consider the relative risks of anti-inflammatories and also paracetamol. In this large cross-sectional study from Scotland, they looked at a database of nearly 2 million people that were registered with over 300 medical practices in March 2007. They found that 65% of people aged over 65 years were found to have 2 or more chronic conditions. So what is the net result of the ageing population? In this graph, we see combined the data from 2 extremely large data extractions from 2 studies. The most frequent combinations with osteoarthritis is hypertension, followed by different combinations of cardiovascular conditions. Following on in the same theme, we can see data from Scotland. On the left-hand axis, we can see the primary disease of patients, starting with coronary heart disease, hypertension, through to any other conditions. On the top axis, we can see secondary conditions, such as hypertension, cancer. But you can also see that 7.2% on average of patients have pain associated with their primary comorbidity. This published systematic review was performed to determine the primary care provider's definition of polypharmacy, and also to explore how polypharmacy was assessed in primary care, and finally to seek tested interventions that address polypharmacy in individuals aged 60 or over. Results showed that polypharmacy continues to be a significant issue, with 61% of people aged greater than 65 taking at least 1 prescription drug, with most taking on average 3 to 5 medications. The most common over-the-counter medications contributing to polypharmacy are paracetamol, ibuprofen and aspirin, and these were not included in the previous numbers. Polypharmacy may also have several important implications in the elderly, including unpredictability in the response to medication and dose, and increased risk of drug-drug interactions. Also, we see that over-the-counter medications can interact or duplicate the action of many of the medications prescribed for cardiovascular conditions in particular. The most frequent mentioned predictor for the development of polypharmacy is actually cardiovascular treatment. I will show you figures on this shortly. For those in the audience over the age of 30, like I certainly am, this slide will partly depress you. As you can see, we have reducing function of our heart, of our kidneys, and also of our lungs. And of course, this is so important to take into consideration when any form of prescribing is done. I find this next data really concerning. A cross-sectional questionnaire-based study was applied to patients with osteoarthritis attending primary care practices. Overall, a return rate of 81% took place. It was found that a high proportion of patients had one or more conditions in which NSAIDs were contraindicated or should be only used with caution, including 55% of patients with hypertension, an almost similar number with cholesterol, heart insufficiency, coronary vascular disease, renal insufficiency, and also stroke. This large meta-analysis based on 39 Cochrane reviews shows the tolerability of varying doses of paracetamol. As you can see, there is only a small number of adverse events that are shown in a variety of clinical studies with paracetamol, and indeed, paracetamol is almost equivalent to placebo in terms of its tolerability. After 30 years of clinical practice, I believe that gastrointestinal tolerability has been central to the safety messages for paracetamol. It is important to realise that paracetamol has no warnings or precautions relating to its GI safety. Because paracetamol is only considered to be a weak inhibitor of the synthesis of prostaglandins that protect the lining of the stomach from digestive acid attack, unlike NSAIDs, and thus paracetamol is not associated with upper GI bleeding. The hepatic safety of paracetamol is always something that is on every doctor's mind. Unfortunately, this partly stems from the unfortunate tendency, due to ready availability, to use this drug in overdose attempts. After metabolism, mostly in the gut wall and liver, the vast majority of paracetamol is excreted in the urine either unchanged or as a conjugate. That leaves the remaining approximate 10% to be metabolized by the cytochrome P450 enzymes in the liver. An intermediate product called N-acetyl P-benzoquinone, NAPQI, is produced, which is highly reactive, but rapidly conjugated or joined to glutathione and then excreted in the urine. So that is what happens in normal circumstances. But if glutathione levels were to be depleted, as in the case of, for example, acute paracetamol overdose, heavy alcohol abuse, or pre-existing liver disease, then the reactive intermediate NAPQI can conjugate to liver cells rather than the glutathione, leading to hepatic damage and potential toxicity. That ingestion of 5 grams or more of paracetamol may lead to liver damage if the patient in particular has other risk factors. Paracetamol has a variety of characteristics that make it the most suitable analgesic for the elderly, particularly when contrasted with ibuprofen. As we've discussed, it is particularly suitable in terms of GI risk. It has less contraindications. It has a lower number of drug-drug interactions. And indeed, it is even suitable for long-term use. Paracetamol and NSAIDs are well tolerated in the vast majority of patients. However, differences in their mode of actions translates into differences in their safety and tolerability profiles. As we have previously heard, paracetamol is well tolerated and does not cause GI, renal, or cardiovascular adverse events. High doses of paracetamol can cause hepatotoxicity. However, this is a predictable AE, one that can be avoided if the correct dosage regime is followed. In general, paracetamol represents a better all-round option for most patients requiring OTC analgesic therapy. In contrast, the tolerability profile of NSAIDs, their drug-drug interactions and contraindications mean that they are a more complex OTC treatment option due to potential GI, cardiovascular and renal adverse events. While COX-2 selective NSAIDs such as celecoxib have a lower GI risk than non-selective NSAIDs, they still have a higher cardiovascular risk. The cause of this risk with NSAIDs is not fully understood, but may be related to various imbalances, such as within prostaglandins. These imbalances may also explain the increased incidence of blood clotting, stroke, and myocardial infarction observed with long-term NSAID use. Compared to other NSAIDs, old-fashioned aspirin causes significantly more GI toxicity due to its potent and irreversible COX-1 inhibition, which of course can also cause the dreadful condition of Ray's syndrome in children. This is just one of several studies that have appeared recently warning about the potential cardiovascular risks of anti-inflammatories and how cardiovascular risks need to be taken into consideration when prescribing them. Though this cardiovascular risk assessment has been discussed in terms of NSAIDs for at least the last 15 years. Unfortunately, all the recent studies indicate an increased risk of heart failure with NSAIDs. Non-compliance is a significant issue in healthcare. For example, there are estimates of 80% non-compliance in asthma care. Thus, it is very important that we explore this issue. So let us look at the various definitions. Compliance, concordance, and adherence are often terms which are used interchangeably. Here are some of the accepted definitions. Compliance is a willingness to follow or consent to the wishes of another person. But compliance does not look at patients' rights or indeed their views. A compliant consultation refers to taking of medications in the right way and does not regard patients' rights. And indeed, non-compliance suggests that the patient has not done what they've been told to do by their healthcare provider. Concordance is the process of prescribing a medicine taking based on partnership, and it refers to the consultation, not the patient. The most important concept which I now wish to discuss is adherence. Here we see some figures from the WHO. There is an estimate that overall global medication adherence is only 50%, and we have this fine balance between the effect of comorbidities and also medication adherence. Medication adherence is an important contributor to effective chronic condition management. Medications are often the primary factor preventing older adults from developing serious complications from chronic illness. Conversely, poor medication adherence is the leading cause of increased healthcare costs, morbidity, and early death. The WHO determined 5 sets of very important dimensions of adherence. We don't have time to consider all of these dimensions today. However, the therapy-related dimension is important to understand. We need drugs that work, i.e. relieve pain, but yet are safe without complex treatment regimes. Wasted or unused medication costs healthcare systems huge sums of money. The first figure we see in this diagram says that the UK National Health Service on average wastes £300 million per annum on wasted medication. Figures from the US say that $270 billion are wasted not just on medication, but also on the consequence of that wasted medication. For example, conditions not being controlled. To help with adherence, here is the product we are considering today, Panadol Extend Osteo and Joint, which is a unique biolayer system which provides both instant and sustained pain relief for up to 8 hours. This is provided by 2 layers within the medication. Firstly, an immediate release of 31%, which gives the immediate release of paracetamol, and also a sustained release layer of the paracetamol, which releases over an 8-hour period. This open, single-center, multi-dose, 2-way crossover phase 1 pharmacokinetic study in 26 healthy subjects was conducted to determine if 3 times daily dosing with Panadol Joint would be able to rapidly deliver therapeutic plasma levels of paracetamol and maintain those levels for up to 8 hours. and to determine whether Panadol joint was bioequivalent to standard paracetamol with regard to total paracetamol absorption. Panadol joint was shown to be bioequivalent to standard paracetamol based on the comparison of the area under the curve during the evaluation period. Fluctuations in peak and trough values were significantly smaller for paracetamol or Panadol joint. Here we see an open label study of 210 patients which compares both paracetamol and joint with normal paracetamol and looks at the patient preferences to the various drugs. Assessments at the end of each treatment phase included both the patient preference for either treatment and also the patient global assessment of response to treatment, plus the satisfaction after treatment with each product. As you can see, across all of the results, the Panadol sustained release formulation was preferred to standard paracetamol across all of the endpoints, thus hopefully improving adherence to treatment regimes involving this formulation. Now I would like to give you some final thoughts. In August 2013, which I remember extremely well, this diagram was released along with the rest of the NICE osteoarthritis guidelines for care and management of osteoarthritis in adults. The important thing was that this was the draft guidance. You will see from this diagram that there was one very important word that was missing, the word paracetamol. After a massive response, including from national and medical press and healthcare professionals against the exclusion of paracetamol, which even involved the MHRA, the British Medicines Regulatory Body, the decision was reversed in the final guidance. After all the consultation, the final NICE guidelines for osteoarthritis were launched in February 2014, and to everybody's relief, paracetamol was then included again. I should note that the next version of these guidelines are due in 2018, and we wait to see what happens then. The paracetamol controversy did, however, raise the question from several other quarters: exactly what other treatments are still available to treat chronic pain, or indeed acute pain, especially over-the-counter treatments? You can see the tongue-in-cheek answer here from one of the national medical press for general practice in the UK. Though for some pains, I'm sure a hug and a cup of tea would work extremely well. So exactly what are the risks of paracetamol that cause this controversy? What I'd like to do now is present 4 of the studies that they did consider. Firstly, there is a large prospective US study showing those frequently consuming paracetamol over a 12-year period had a 35% increased risk of a major cardiovascular event, such as a myocardial infarction. Secondly, there was a UK study reviewing 1.2 million GP records, which showed several different parameters, including a 28% mortality increase with paracetamol use, and a 14% increase in heart attacks, and a 20% increased risk of renal failure with paracetamol use. The ORSI evidence review for various analgesics in OA showed that accumulating evidence suggested high-dose paracetamol has upper GI side effects. There was also some evidence to suggest that mild loss of renal function following the long-term high dose of paracetamol occurred. Finally, in 2011, Nottingham University researchers reported an increased risk of hemoglobin reductions, thus indicating GI bleeding, after 13 weeks of ibuprofen and paracetamol alone. The risk doubled when both drugs were taken in combination. So here are some of my thoughts regarding this controversy. Large studies do not differentiate between acute and chronic use of paracetamol. The acute and thus the short-term use of paracetamol is proven. Chronic long-term use is more contentious. Over-the-counter use of paracetamol tends to be of lower dose and of shorter duration. The alternatives for chronic pain, such as NSAIDs and opioids, also carry risks of significant morbidity and mortality. It's important to realise that paracetamol use may be a marker for other medical conditions which cause the need for regular paracetamol use as well as complications such as cardiovascular, renal and GI disease. Harms of pharmacological therapies are compounded when taken in combination, and the NICE guidelines noted that this is often the scenario that patients find themselves in, either in the short-term flare-ups of their conditions or in the longer-term management. The NICE guidelines of 2013, commenting on the potential issues with paracetamol, said, overall, the quality of evidence reviewed ranged from very low to moderate quality. Problems included lack of blinding in studies or selective outcome reporting. Thus, we really do not know exactly what the situation is with this evidence. I would now like to present my thoughts on a stepwise treatment approach for osteoarthritis management, particularly in mild to moderate pain. I have based these guidelines on the EULAR recommendations and also some of my own thoughts. Firstly, and importantly, the core three therapies of information, diet, and exercise. Secondly, I would say that what we need to do is combine oral paracetamol intermittently with topical NSAIDs intermittently, and then we can titrate that to the requirements of the individual patient. For those that do not respond to the oral paracetamol and topical NSAIDs, we might want to introduce oral NSAIDs. And finally, if oral NSAIDs don't work, we should progress to mild opioid treatment. In summary, the problems to the individual and also society caused by both chronic pain and osteoarthritis are immense. Whenever possible, patients need an accurate assessment at the start of their pain management journey. Self-management of pain, including joint pain, is the reality for many. There are many multiple international guidelines that exist to support the use of paracetamol in the treatment of osteoarthritis. Oral NSAIDs should be avoided in patients at risk of cardiovascular disease. Risk factors include being overweight, high blood pressure, high cholesterol levels, smoking, and previous history of a myocardial infarction. Most osteoarthritis patients also suffer from other conditions like GI intolerance and renal diseases, where oral NSAIDs are either cautioned or contraindicated. A combination intermittent NSAID cream and gel regime with intermittent paracetamol should be considered as first-line medication treatment in osteoarthritis. Thank you.